Thank you again to everyone for joining our Cancer Genomic Consortium webinar today. And I just do a brief introduction and a bit of housekeeping items before we get started. First of all, we have a very exciting 45 to 50-minute talk by Dr. Kathleen Schieffer. And after that, we will have about 10 to 15 minutes for question and answer. And if you could kindly put your questions in the Q&A box, please, and do not put in the chat box because we do not monitor the chat box. So do put in the Q&A. So I just want to go right into introducing our great speaker today. Dr. Kathleen Schieffer is a clinical laboratory director at the Institute for Genomic Medicine at Nationwide Children's Hospital, and also an assistant professor at Ohio State University. She received her PhD degree in biomedical sciences and clinical and translational science at the Penn State University, and she completed her postdoctoral work at Nationwide Children's Hospital with a focus on genomic and transcriptomic analysis in cancer. And after her postdoc, she went on to do her LGG, Laboratory Genetics and Genomics Fellowship at Nationwide Children's. So she's now a leader of the Cancer Genomic Consortium Sarcoma Working Group, of which I'm a member, and I've really had a great experience working with her, and she has a great story to share about current state of diagnostic testing in pediatric sarcoma. So the stage is yours, Dr. Schieffer, and we'll be listening, and we'll have our Q&A. Thank you.
Thank you so much for that great introduction, and let me get my slides up. All right, so it looks like you should be seeing my slides now. So thank you again to Tui for the great introduction, and to the CGC for the opportunity to present on behalf of the Sarcoma Working Group on the current state of diagnostic testing in pediatric sarcoma. Our learning objectives are here. So quickly, we're going to identify how differences between pediatric and adult cancers may impact diagnostic testing, discuss challenges in the field of pediatric sarcoma diagnostics, and then summarizing the advantages and limitations of cytogenetic and molecular methodologies that are commonly used in a diagnostic setting. So to start, I first wanted to acknowledge the members of our working group for all their work on this project and the preparation of our manuscripts, which are currently under review. This has really been a wonderful and collaborative experience, and I'm so thrilled to be able to share our work today. I also wanted to highlight the memory of Ruth Ann Fowle. She actually started this working group and was the leader. She developed this following a roundtable discussion at a CGC annual meeting. Ruth Ann passed away in 2022 after a hard-fought battle with a brain tumor, so our work continues on in her memory. So I want to start with just a little bit of history on the Sarcoma Working Group and how this came about. In 2018, larotrectinib, which is a TRAC inhibitor, was granted accelerated FDA approval for adult and pediatric patients with solid tumors. So this would include soft tissue sarcomas harboring an NTRK rearrangement. Ultimately, this resulted in genomic testing for pediatric sarcomas becoming even more important for optimizing patient care. In 2019, the CGC Sarcoma Working Group was established with the goals to understand the genomic testing landscape for pediatric sarcomas, as well as provide a bit of education. So recommendations or best practices based upon the work group's experiences. And we're hoping to do this using example case scenarios. So to end my talk today, we do have 2 case scenarios that we're going to walk through and hopefully have some discussion within the group, within the chat. So an overview of pediatric sarcomas. Sarcomas are tumors that arise in bone or soft connective tissue. So you think things like muscle or fat or blood vessels. Some of those that probably most commonly come to mind for the pediatric setting are rhabdomyosarcoma, which is a soft tissue tumor, osteosarcoma, which is commonly found in the bone, and then Ewing sarcoma, which can also be soft tissue or bone. If you look at the graph on the right-hand side of the plot, using data from the SEER program, I have highlighted in red those that are the sarcomas from this pediatric cohort. And what we can hopefully appreciate is that collectively, as well as individually, pediatric sarcomas are rare. Depending upon which source you look at, it's estimated that about 6 to 15% of all childhood or adolescent young adults, or AYAs, their tumors are considered a pediatric sarcoma. Notably, these are highly diverse and heterogeneous group of tumors. The last source that I checked mentioned there's probably about 70 different types of sarcoma. And each of these have a unique biology and a genetic driver. Fortunately for us, many of these tumors also have pathognomonic rearrangements or alterations, which can aid in diagnostic refinement. So we'll go through these in a couple of slides, but just a couple examples that this group might be familiar with. So Ewing sarcoma is associated with an EWSR1 Fly1 fusion. At the cytogenetic level, you can see this appreciated by a balanced translocation between chromosomes 11 and 22. Alveolar rhabdomyosarcoma is associated with either a PAX3 or PAX7 FOXO1 fusion. And again, we can appreciate this at a cytogenetic level due to a translocation between either chromosomes 2 and 13 for PAX3 FOXO1 or chromosomes 1 and 13 for PAX7 FOXO1. Previous studies on the molecular analysis of these tumors are somewhat limited. We know this is a rare group of tumors. Many of these studies are small sample size, or they are based more toward a specific histology. So, for example, a study of just rhabdomyosarcoma, for example. But there's many rare tumors that are really appreciated in the literature by case studies. And one of the points that I'm hoping to really get across in today's talk is that the landscape of soft tissue sarcomas differ between pediatrics and adults. So in this nice figure that is shown here, we're seeing different types of soft tissue sarcoma histologies separated by different ages. So on the left is your pediatric population, so 0 to 9 being first, 10 to 19 second, and then 20 and over following that. Visually, what I hope you can appreciate is that the colors or these profiles differ once you leave that pediatric age group. So for example, if we look at the bottom most color, that dark blue color on the bottom, that is rhabdomyosarcoma. That is seen in about 60% of soft tissue sarcomas in that 0 to 9 age group, and roughly 25% in that 10 to 19. That number drastically drops off, though, once you hit that 20-year-old and over. What you can also see is the adults have a different set of tumors that are most common as well. So that green cohort is leiomyosarcoma. That sort of mustardy yellow is liposarcoma. And then that teal blue is Kaposi sarcoma. So we see these frequently in adults, but you can appreciate that they're not well represented in the pediatric population. The point that we're trying to make with looking at the differences between pediatrics and adults is that when you're looking at molecular studies and you're developing gene panels, many of these were derived from the adult tumors. So you want to make sure that whatever testing you're performing is actually representative of that pediatric disease, especially since there is such diversity between adults and pediatrics in sarcoma. And finally, just to drive home the importance of genomic testing for sarcomas, this is a paper that came out in 2022 that looked at 7,500 roughly tumors. This includes pediatric, AYA, and adult patients with sarcoma. These individuals underwent sequencing using the Foundation 1 heme tumor panel. So this is a tumor-only sequencing. It's a targeted approach. And ultimately, what this study found was that about 10.5% of these patients had a refined diagnosis based on their molecular testing. And really, this refinement or reclassification came about due to the identification of recurrent pathognomonic translocations or alterations. So just to draw your attention to the figure on the right-hand side of the slide, the original diagnosis is shown first. And then if you follow that colored bar to the right-hand side, which is the corrected diagnosis, is following molecular testing, what the new diagnosis would be. Importantly, the one that I found to be most important is the sarcoma NOS, or sarcoma not otherwise specified. So these are tumors that you diagnose them as a sarcoma. You really can't dive any further beyond that. So with molecular testing, they are able to then provide this a more clear diagnosis. So for example, solitary fibrous tumor, synovial sarcoma, Ewing-like round cell sarcoma. Some of these may have both diagnostic implications, obviously, but they could also have therapeutic or prognostic implications. So being able to provide that accurate diagnosis is highly important for these particular sets of tumors. So I'm going to switch gears and talk a bit about our survey. So our sarcoma working group put together a pediatric sarcoma genetic testing landscape survey back in 2022. The goal was to better understand what at that time was the current landscape of genetic testing for pediatric sarcomas. The survey was sent to CGC members and general constituents, as well as individuals on the CytoGen listserv from April to May of 2022, and ultimately we received 46 responses. So we're going to go through some of the results from our survey, intermixed a bit with information regarding the different methodologies and advantages and limitations. So to start with a couple of demographic slides, we asked individuals what your practice setting was and where your institution is located. So we found that the majority of our respondents were from university, academic, or teaching hospitals, and most were based within the United States. However, we did have representation from Canada as well within our survey. When asked what the primary role of the individual responding to the survey was, the majority were either a laboratory director or pathologist. We did also have a few clinicians, oncologists, or clinical laboratory technologists respond to the survey as well. And then speaking to the rarity of pediatric sarcomas, when we asked how many pediatric sarcoma tumor specimens underwent genetic testing annually at your institution, the majority, or 44% of our respondents, saw 50 or less of these tumors annually. If you add the next 23%, which saw 51 to 100, we're looking at just over 60% of our respondents who see at least 100 of these samples. So again, this is speaking to the rarity of these particular tumors, and there's not very many of them that are undergoing testing at these particular laboratories within the year. We next asked about the different sample types that are received for in-house genetic testing. We can see that almost universally, labs were able to test from formalin-fixed, paraffin-embedded, or FFPE slides or blocks. Next, most frequently, we had fresh or frozen tissue, as well as bone marrow aspirates for metastasis evaluation. Less frequently, but still around 30% of respondents were able to receive fine needle aspirates, touch preps, or cytology smears, as well as samples for germline analysis, so blood, saliva, or buccal swabs. Fewer institutions received other body fluids, such as cerebrospinal fluid. And finally, we also asked about what types of clinical testing are offered for pediatric sarcoma in-house. So what have you clinically validated within your laboratory that you're able to perform? What you can hopefully appreciate from this table is that the majority of respondents are performing cytogenetic techniques. So conventional karyotyping was utilized by 61% of our respondents and FISH by 87%. Those targeted molecular assays are being used, but less frequently. So about 30 to 40% of respondents used a comprehensive pan-cancer targeted sequencing panel, a targeted gene fusion panel, microarray or RT-PCR. While there's more comprehensive analyses, so whole transcriptome sequencing or RNA sequencing, exome or genome sequencing was used by a relatively few of our respondents. So the next couple slides are going to go through each individual technology, as well as we had some supplemental questions. If a respondent answered yes, they use this particular methodology, and we wanted to get a bit more detail about what they are actually testing for. So we're going to go through those here. So first is conventional karyotyping. This is an analysis that looks at chromosomes from individual tumor cells to look for both structural and numerical abnormalities. Historically, this has been a gold standard methodology for detecting recurrent aberrations in pediatric sarcoma. Many pediatric sarcomas are associated with gene fusions that are derived from translocations, so this is a great approach to identify those particular translocations. So some of the advantages of conventional karyotyping is it does provide that genome-wide assessment. you are evaluating single cells, so you can detect tumor heterogeneity, as well as this relies on a cell culturing method. So because you're culturing cells, you are able to expand your tumor quantities if you want to save something for future studies. However, there are also challenges with conventional karyotyping, and that you must have fresh tissue available. It cannot be fixed, it cannot be frozen. Because you are culturing those cells, it can have a longer turnaround time. Additionally, the culturing technique for these solid tumors can result in a high culture failure rate. These are technically challenging to culture and require great expertise from cytogenetic technologists to maintain these cultures over time to have viable cells to analyze by karyotype. Depending upon the malignancy, the karyotype might be highly complex and labor intensive to characterize. So I mentioned many sarcomas are characterized by gene fusions and a translocation. That's one cohort of sarcomas. The other cohort are those that are genomically complex. So thinking of something like osteosarcoma, which may have chromatopsis and numerous breaks and rejoining of chromosomes throughout the genome. So when you have something like that, it can be very complicated to actually karyotype correctly. Additionally, with cancer chromosomes, you typically have lower resolution. The morphology can be a bit challenging. So some of these might just be difficult to characterize due to those facts. FISH, this was most frequently available by our survey respondents for pediatric sarcoma. So this is a methodology that uses a fluorescent probe that binds to a target region of the DNA. So in this case, you might be looking at one gene in particular. Most commonly, what we saw used were break-apart probes that target a single gene. So if a rearrangement is present, such as what's shown on the image here, the red and green signals separate. So that fusion signal that you're seeing right here is a normal signal, and then these two separated red and green signals would represent a rearrangement of that particular gene. Advantages of FISH is that you can use either fresh, frozen, or fixed tissue. These can have a fast turnaround time if you need results quickly. In some cases, you might be able to get results out in 24 to 48 hours. Again, you're evaluating single cells, so you are able to detect tumor heterogeneity. And in these cases, you tend to review a large number of cells. So if there is a low-level aberration, even if you have a sample with low tumor content, you might be able to pick that up by FISH. However, with FISH, you do need to have prior knowledge of the target or targets that are of interest. So essentially, each gene or each probe that you're looking at has to be clinically validated on its own. You do not have an ever-expansive library of probes available. That's just not feasible for the laboratory. This does not provide information on the reading frame or the fusion partner, so you're really only getting information on that one particular gene that you're testing by that FISH probe. And then there is potential for false negative results, depending on the cutoffs that are established by the individual laboratory. So as a supplemental question, for those that answered yes, that they perform FISH within their lab, we asked about the availability of 18 different probes that you can see listed here on this lollipop plot. 39 of those 40 respondents answered this supplemental question. And we saw of those, 98% had EWSR1 FISH probe available. And the next most common would be FOXO1, ETV6, and ALK. So notably, EWSR1, FOXO1, and ETV6 are all break-apart probes. So again, you're only assessing for that single gene partner that is identified. Interestingly, also from our survey though, we saw that the partner of those common genes are less frequently available or less frequently clinically validated by the lab. So highlighted in red are the three most common, and then highlighted down in blue are those fusion partners. So PAX7 and PAX3 for FOXO1 were only available in 5% of labs, and then NTRK3 with ETV6 was only present in 21% of labs. So in some cases, this second gene partner, NTRK3 or PAX3 or PAX3 or PAX7, might actually be needed for clinical information. So this could provide additional diagnostic information, but for example, in the setting of NTRK3, this would provide therapeutic information, or PAX3, PAX7 would provide prognostic information beyond just the initial probe that you test. So targeted RT-PCR followed by Sanger sequencing. This is a molecular assay that sequences across a fusion breakpoint using specific primer sets that target generally the most common fusions and common fusion breakpoints. So you can see an example of what this would look like on the bottom for an ETV6 and NTRK3 fusion. where we get a sequencing product across that fusion breakpoint that represents ETV6 exon 5 and NTRK3 exon 15. Some advantages of this is that this is a cost-effective assay. You can have a fast turnaround time, and you are able to multiplex, so you can look at multiple fusions within the same assay. However, this is a targeted approach, so both gene partners need to be evolved. If you have, for example, an ETV6 with a different fusion partner, you're not going to pick that up by this assay. Similarly, if you have a non-canonical breakpoint or a breakpoint that's not covered by the primer set, you're going to end up with a negative result as well. So using the example shown here, if your fusion breakpoint was an exon 16 of NTRK3, you would not be picking that up by this assay, assuming your primer only lives in exon 15. And finally, when you're thinking about FFPE and frozen tissue, we know FFPE has a lower tissue quality. It tends to be more degraded. You have to have smaller product sizes for this assay. So depending upon how you validate your assay, you might need multiple primer sets that are specific for either FFPE or frozen tissue. So as a supplemental question, we asked the 10 respondents who answered yes, that they performed targeted RT-PCR, if they had available testing for those 6 fusions that are listed on this slide. 7 individuals responded, and we saw that all 7 had the availability of EWSR1 Fly1 for Ewing sarcoma, as well as PAX3 and PAX7 FOXO1 for alveolar rhabdomyosarcoma. Still highly represented, but not at 100%. We saw sites had EWSR1 ERG for, again, another Ewing sarcoma fusion, ETV6 NTRK3 for infantile fibrosarcoma, or SS18 SXX for synovial sarcoma, seen in 71%. Targeted gene fusion panels. This is an assay that is typically derived from RNA, and you have the ability to assess in this case for fusions from many different genes. Depending upon the assay that is used, the fusion might be called if you have a single gene on the panel. So this would be able to pick up novel fusions. So again, going back to our example where you had an ETV6 with a novel fusion partner, this particular assay would be able to detect that novel fusion partner. Or there are also fusion panels that require both genes to be on the panel. So you're only able to detect those known fusions that have known fusion partners. Some advantages to a gene fusion panel: you do have the ability to customize panels to your specific patient population. As mentioned, depending upon the technologies, you might be able to detect known or novel fusion partners. These types of assays can be validated from many different sample types and evaluate many different genes at the same time. Relative to RT-PCR, this can have a longer turnaround time. It does tend to be more expensive, and it does potentially require a strong bioinformatic infrastructure for data processing and analysis. Going back to a previous slide discussing the difference between adult and pediatric tumors, many of the off-the-shelf products may be representative of the adult tumor genomic landscape. So the question, if you're using an off-the-shelf product, does the gene content actually reflect the tumor types that you see in your patient population? If the answer is no, you might want to consider customizing that particular assay. So in our survey, we asked those 16 individuals that answered yes, what type of panel they use. Is it a commercial panel or a custom panel? We asked them to provide the actual panel that they utilize, as well as the number of genes. So you can see those listed here with the purple table showing the commercial panel. So this would be off the shelf, and the custom panels below. What we can appreciate is there's a variety in the number of genes that are evaluated. So from 43 up to 1,300. In some cases, it's going to be variable when you customize your panel as well. And then we can also see whether these are able to detect those novel fusion partners. So you only need a single gene on the panel, or if it's only able to detect known fusion partners. The comprehensive pan-cancer targeted sequencing panel. This is another next-generation sequencing-based approach that typically assesses for genes that are commonly involved in cancer. It's not necessarily just sarcoma or pediatric sarcoma. These tend to be genes that are altered more broadly in cancer. The types of variants that are reported can differ based upon which panel you are using, if your panel is going to have its own advantages and limitations. There's also two different approaches you can take for these sequencing panels. There's a tumor-only approach where you sequence just the tumor, and then there's a paired approach where you sequence the tumor as well as a germline sample. You're able to then detect if the variant is present in the tumor-only or if it's present in the germline. So tumor-only analyses, the advantage is this tends to have a lower cost than a paired analysis. You're only sequencing one sample. It does not require a germline sample or informed consent. And with any sequencing panel, you have the potential to identify small variants, so single nucleotide variation, indels, copy number variation, or loss of heterozygosity, or CNV LOH. Some of these may also be able to detect structural rearrangements or gene fusions. This does have a longer turnaround time. It's going to be more expensive than an RT-PCR, for example, or other assays. And then one of the major drawbacks or limitations of tumor-only testing is that the etiology of the called variant is uncertain without confirmatory testing. So what I mean by that is you get a result, you're not able to determine if that variant is actually somatic or if it's germline. These also tend to be targeted assays. So again, depending upon the assay that you use, you may only be able to detect well-described hotspot variation, or it may be a more broader test which would identify any variants within the genes that are on that panel. For the paired analysis, one of the advantages here is that you are able to determine the etiology. So is this a germline variant? Is this a somatic variant? Or is it a mosaic variant? Similarly, you can identify many different types of variation depending upon what platform is being used. And importantly, for pediatric sarcomas and pediatric cancer in general, having this paired analysis really allows you the ability to detect cancer predisposition in that individual. Some limitations: this particular testing is more expensive than tumor only because now you are sequencing two different samples. It again has a long turnaround time, and it does require that germline sample. Potentially, it might also require informed consent. So this could potentially delay testing. So if you saw a patient in clinic and didn't get the germline sample and they're not coming back for another 3 months, you could potentially delay that testing 3 months because you're not able to get that germline sample until then. And then again, depending upon what assay, it's targeted, so you may only be able to detect well-described variation. So as a supplemental question, we asked those individuals who answered yes, what nucleic acid was evaluated? Was it DNA only, RNA only, or both within the same assay? So 75% or 9 out of the 12 that responded were assessed both DNA and RNA in the same assay. So this allows for the identification of not only variants, but also fusions or structural rearrangements. We also found that tumor-only testing was more common. So 10 out of the 12 or 83% of respondents had tumor-only testing. On the right-hand side, you can see the types of variants that our respondents listed that they were reporting out of their sequencing panel. And then I also added an exome and genome here. You can see that we had relatively few respondents that report out of exome or genome, but wanted to include this to show the variety in different types of variants that are being reported. So we can see somatic variation, which is shown in red, is highly reported amongst all 3 different assays. Structural variants or fusions is also relatively common, so that's shown in purple. And then copy number was only seen at about 50% of respondents who answered that they perform sequencing panels, and then about 30% have the ability to detect germline variation. For exome and genome, it was about half and half who performs paired analysis versus a tumor only. So with all this, I wanted to raise the point that every laboratory is unique and that we all serve a different patient population, which ultimately can lead to differing workflows. This actually led to really great discussions within our work group about what each of us do for testing. Ultimately, though, there are no standard recommendations for what test or tests are most appropriate for pediatric sarcoma. Hopefully you can appreciate some of the challenges with trying to provide a one-size-fits-all recommendation for how to test for pediatric sarcoma, given that it is a highly diverse, heterogeneous group of tumors. Additionally, when you think of your testing workflow, this may depend on What is that experience at your institution? Does your institution predominantly do cytogenetic testing, or do they predominantly do molecular testing? That might skew your workflow into one of either directions. What tests do you have validated in-house versus what does your send-out testing look like? Additionally, the type of tissue, as well as the amount of tissue, is highly important here. So if you only have fixed tissue, that could potentially limit the tests that you're able to perform. Similarly, with sarcomas, you tend to have potentially very small amounts of tissue available. That could limit your ability to not be able to do that comprehensive testing that you want to do, and maybe you have to be very choosy in deciding what is the best test for your particular patient at that time. Additionally, we have to think about turnaround time. So many of these bigger sequencing panels, exome, genome, fusion panels, a lot of those are going to have a longer turnaround time than, say, FISH, for example. So if you need a really quick answer for your patient, FISH might be the way to go versus some of these other assays. But again, that's going to be dependent upon the clinical information and discussions with your providers around what their desired turnaround time is for patient care. And importantly, if you have results from multiple testing modalities available, you should consider correlating those results to help aid you in your interpretation. So what I mean by this is if you're a lab that maybe performs both a sequencing panel and a fusion panel, if your fusion panel gives you a positive result that is characteristic of that particular tumor, maybe it's not surprising that your sequencing panel is negative. And the final question of our survey. So we asked an open-ended free text question, and we really wanted to get an idea of what are the conundrums that we are currently facing in the field of pediatric sarcoma genetic testing. We took all of those answers and we were able to divide them up into different categories, which is what you're seeing here. So the majority of the respondents mentioned that there was a scarcity of testing algorithm guidelines. Again, this is a challenge for pediatric sarcoma, so it doesn't surprise me that this is the most common issue that was being identified from our survey, but it's also going to be a very challenging one, I think, to resolve. Lack of support for new test development and issues with send-out testing was second most frequently reported. As the field starts moving more towards these larger molecular-based assays, many felt that there was insufficient knowledge to interpret or act on their results. Some of these big molecular assays can have very complicated results that can be difficult to interpret from the clinical side. Another question was, when do you perform germline testing if you're doing a tumor-only analysis? Insurance and reimbursement complications was also noted as an issue, as well as limited tissue for comprehensive testing. So with that, I want to switch gears, and I have two case scenarios that I want to walk through with hope for a little bit of interaction from the group. If you can put your answers in the chat. I'm curious to see what you would do next. There's no right or wrong answer. It's more of a curiosity based upon the discussions and the variability of what we saw within our work group. So case scenario one, this is a full-term female who was born at a community hospital. At birth, she presented with a large mass on her face, which you can see highlighted by the orange arrow. This particular mass was biopsied at 1 week of age. So histologically, this was most consistent with an infantile fibrosarcoma. So what is this tumor? It's a malignant tumor that commonly occurs in infancy. It is most frequently associated with ETV6 and TRAC3 fusion due to a 1215 translocation that you can see cytogenetically. There are also other drivers of infantile fibrosarcoma should ETV6 and TRAC3 be negative, but by and far, this is the most common finding that you're going to see. Really important for this case, though, because it is associated with an NTRK fusion, it can be treated with a TRK inhibitor. However, this does require the identification at the genomic level of an NTRK rearrangement. So that's something to keep in mind as we walk through this case. Other differential diagnoses for this particular case: spindle cell rhabdomyosarcoma, inflammatory myofibroblastic tumor, and infantile myofibroma. So we're showing a panel of immunohistochemical stains below, if they were positive or negative, and how that helps to either rule in or rule out a particular differential diagnosis. Ultimately, though, this doesn't provide a clear diagnosis of infantile fibrosarcoma. and genetic testing is necessary. So in this particular case scenario, this is an institution that is highly experienced in cancer cytogenetics. So they have a cancer cytogenetics lab. So tissue was sent for conventional karyotyping. You can see a representative image of the karyotype below, which shows a balanced translocation between chromosomes 12 and 15. So the abnormal chromosomes are highlighted with the red arrows. And on the right is the ideogram of that rearrangement, where chromosome 12 is shown in blue and in orange is chromosome 15. You can appreciate the translocated products on the end of 12p and the end of 15q. So given we have this 12-15 rearrangement, further testing was needed. So this particular laboratory has a limited panel of FISH probes that are validated for clinical use. You can see those 5 FISH probes shown below. So ALK, ETV6, EWSR1, FOXO1, and SS18. Given that you have this 12-15 translocation, you're suspicious for an ETV6 and TRAC3 fusion. So ETV6 FISH was ordered. This is the results. So you see that interface cell that has 1 fusion signal, 1 red signal, 1 green signal. What this is showing is a separation or a break apart of 5' ETV6 from 3' ETV6, and ultimately is positive for an ETV6 rearrangement. So this is where I want you to think, what would you do next? And within your laboratory, if you had these results, what would you do? And I would love if you would put answers in the chat just so we can see maybe what different groups would do or how other people have their thought processes. But just to summarize what we know so far, we have a histopathology consistent with an infantile fibrosarcoma. Conventional karyotyping identified that 12-15 translocation that is commonly associated with an ETV6 and TRAC3 fusion. And we have FISH with an ETV6 rearrangement. However, we do not have any information on that fusion partner, and that cannot be ascertained from this testing. So what would your next steps be if this patient was seen in your laboratory, in your clinic? So some of the next steps you can think of, and again, there's no right or wrong answers here. If it's available, you could do NTRK3 FISH. This would confirm that it's an NTRK rearranged infantile fibrosarcoma, and it would ultimately confer that eligibility for a TRK inhibitor. However, what we found from our survey is that only 21% of labs had an NTRK3 FISH probe validated. So it's not a probe that is commonly available in the clinical setting, not, as we saw in our case scenario, not available for that particular institution as well. So if you don't have NTRK3 FISH, what are your options? You could do send-out FISH testing. There's a send-out lab that likely has NTRK3 FISH that you could send slides to and have them do the FISH for you. You could also consider molecular methods, so something like a targeted RT-PCR, or if you want to go more broadly, a gene fusion panel could also be considered. All right, we're going to move on to case scenario 2. So this is a 2-year-old male who presented with upper back pain and a palpable mass. The histology was consistent with an embryonal rhabdomyosarcoma with diffuse anaplasia. You can see some of the IHC stains here. Desmond myogenin and MyoD1 were positive. Embryonal rhabdomyosarcoma is commonly associated with alterations within the RAS-MAPK signaling pathway. And the absence of a FOXO1 fusion can help to distinguish between embryonal and alveolar rhabdomyosarcoma. When you see the diffuse anaplasia, this is typically or may commonly be associated with a TP53 alteration. Also wanted to note that there is a family history of cancer in this particular patient. So in this family, we saw cancers of soft tissue, brain, and bone. This is going to be an NGS-based assay, so we're going to look at a pan-cancer targeted sequencing panel. So when we do sequencing, we like to have a pathology review of a representative section of tissue that is adjacent to the section of tissue undergoing nucleic acid extraction. This gives us an idea of exactly what that tumor content is most likely to be in the sample that we are using for our sequencing technology. So in this case, we are estimating about 60% tumor content in this sample. And that's a number that I just want you to keep in mind as we look at the results on the next couple of slides. So first, we're going to look at if this was a tumor-only panel. So for our tumor only, we identified two variants that were identified. One is a TP53 hotspot. This is a missense variant at amino acid 282. In ClinVar, this is listed as pathogenic, likely pathogenic, and it has a variant allele frequency or fraction of 99%. The second variant that was identified is a KRAS variant. This is a G12V, so this is another hotspot that has also been reported in ClinVar as pathogenic. In this case, the variant allele frequency, or the VAF, was 30%. So with these results, and in mind that this is a tumor-only assay, you might want to start thinking of, do you need to recommend germline testing for maybe one of these variants? So first, looking at that TP53 variant, you have a VAF of nearly 100%. So this could represent a germline finding, particularly if that tumor is expected to have diminished tumor content, as we're seeing in this particular case where it was estimated at 60. So when you think about tumor content, you think you have about 60% of cells representing that tumor. The rest of the 40% of cells that are making up that sample are the normal tissue, the non-tumor tissue. So for a VAF to be near 100%, you would have to have that particular variant being observed in both the tumor cells as well as the normal cells, and you have to have a second hit that affects that locus to make it a biallelic alteration. So this particular finding could represent a germline arginine 282 tryptophan variant that has an additional copy number loss or loss of heterozygosity of 17p. However, it could also be a somatic variant. So we do estimate 60% tumor content. With that, you would expect a monoallelic alteration to have a VAF of around 30. If it's biallelic, it would be about 60%. So again, those 40% of normal cells are not affected or do not have this variant. So 60% VAF would represent 2 hits to that particular allele. However, we do know that estimating tumor content is challenging, and it can be underestimated, overestimated. So if for some reason the tumor content is underestimated and it's actually near 100%, this VAF of 100% could indicate a somatic variant with, again, an additional copy number loss or LOH. The KRAS variant is not likely to be germline given the VAF and the clinical history. It's likely to be a monoallelic alteration. So again, it's at that about 30% VAF in the tumor, or it could be a subclonal somatic alteration that's found in the tumor only. So this is looking at a tumor-only analysis. We're now going to look at the same results, but in this case, we have a paired analysis. So we have a tumor and a germline sample that's better able to help us distinguish etiology. So in this case, we see, again, that TP53 variant is actually germline in nature. So in the germline, it's right around that 50% VAF, which would be a heterozygous finding, consistent with an autosomal dominant disorder, Li-Fraumeni syndrome. We do have likely a second hit that's a copy number finding that is leading to that 99% somatic VAF. We can also determine that the KRAS variant is actually just somatic in nature. So we are seeing it here in the tumor only. It is absent in the germline. So germline cancer predisposition, this is, as I mentioned before, highly important in the pediatric cancer population. It's estimated that about 10 to 15% of individuals that have a pediatric cancer have a germline predisposition. This not only has an impact to that patient, but it also can have an impact to that family as well, and could trigger cascade testing of other family members who then might require additional surveillance. So this table is looking at a number of different cancer predisposition syndromes, as well as their predisposition to just sarcomas. That's not saying there aren't other cancers that they're also predisposed to, but we're keeping this focused on sarcomas here. So our prior case study was looking at Li-Fraumeni syndrome, so a TP53 germline variant. We saw that family history of bone cancer, soft tissue cancers. They also tend to get brain cancers as well. So this fits well in line with the clinical history that we saw. One of the questions that came up as part of our survey is, when do I do germline testing in the setting of tumor-only analysis? So I pulled here 4 different either points to consider or recommendations that have been published for how should you interpret germline testing in the setting of this somatic-only sequencing. Wanted to touch just a couple high-level points that came from these papers. So you want to take into consideration 2 different things. First, the clinical information. Do you have a family history of cancer? Is it a tumor that is known to be associated with cancer predisposition? Do you have an earlier age of onset? So in many cases, those with cancer predisposition have cancers at a very, very young age, but you could also think of this in the setting of like breast cancer, for example, with a BRCA alteration, where it's just an earlier than typical age of onset. Additionally, if you have bilateral or multiple cancers, you're more likely to have germline predisposition versus if you have unilateral disease. You can also look at the variant itself to help identify whether something might be recommended for germline testing. So is it a known founder variant that is commonly described in the germline setting? Is the variant also known to be described in germline or somatic tissues? As we saw from our case, the variant allele fraction or frequency can maybe provide some information, but it's not going to be a perfect system for saying, if I have this VAF, I would want to recommend germline testing. So typically, you would see a VAF close to 50. However, due to the tumor biology, it may be outside of this range. And we saw that in our example, where we had a second hit to TP53, which led to a VAF of 100%, but ultimately that ended up being a germline finding. And to end today's talk, I just wanted to touch on a couple emerging technologies for pediatric sarcomas. So first is DNA methylation array-based classification. This is a method that has been commonly used in the CNS setting. So it's using a methylation microarray and comparing that global methylome signature to a reference cohort. So there is a classifier that is specific for soft tissue sarcomas. You're actually seeing the t-SNE from that particular classifier here for the sarcoma samples. And there's 62 different methylation classes that your tumor might classify in. As part of the classification, you get what tumor type does this most closely fit, or what methylation classes most closely fit, as well as a score which can provide confidence that, yes, it's a good fit for that particular tumor, or maybe it's not a great fit if the score is lower than 0.7 or 0.6, for example. Comprehensive classification. So the National Cancer Institute and Children's Oncology Group have an initiative called the Molecular Characterization Initiative, for which newly diagnosed patients with soft tissue sarcomas, as well as other tumors, are able to get comprehensive characterization of their tumor sample. So this includes a paired exome sequencing analysis, so again, looking at that germline and that tumor sample, as well as an Archer fusion panel for soft tissue sarcomas. These are clinical assays. The report is able to then go back to the provider for use in clinical care. Methylation arrays, this is, the testing is performed, but a report is not provided back to the provider, as this test has not yet been validated in the clinical setting, but is used for research purposes. One of the exciting things about the Molecular Characterization Initiative is all of the data, the raw data, as well as the redacted reports, are being made publicly available through dbGaP to help inform future research. So if we go back to the very beginning of the talk, I mentioned that many of the studies are small in sample size. So this is an initiative that is able to get some of these sample sizes to be a much larger cohort for some of these more comprehensive studies. And then finally, just to touch on optical genome mapping. So this is a method that uses ultra-high molecular weight DNA to look at genome-wide high-resolution interrogation of both numerical and structural rearrangements. We've heard a lot about this in the hematologic malignancy setting. Recently, a paper came out, probably one of the first papers that has looked at this in soft tissue sarcomas and bone tumors. And the figure here is actually from that paper. So one of the challenges here is that many of these samples do tend to be FFPE, which is not conducive to OGM. You really need that ultra high molecular weight, long DNA strands for this. So this is, I would say, very early in its stages, but it looks like it's going to end up being a promising tool once some of the methodology gets better developed. And with that, I want to thank everybody for their attention, and I'm happy to answer any questions.
Well, thank you so much, Dr. Schieffer, for a wonderful and very informative talk, and how collaborative work among Cancer Genomic Consortium members really create really new insights into a relatively rare tumor class of pediatric sarcoma. So we would like to open the forum now to questions and answers from the audience. Please do remember to put your questions in the Q&A box and not in the chat box. And I am just going to open with two questions from the Q&A from the audience. All right, so our first question is the karyotype not sufficient for eligibility for TRK, tyrosine receptor kinase inhibitor therapy? Is molecular confirmation necessary?
So a karyotype alone is not sufficient. So the karyotype tells you there is a 1215 translocation. It does not provide that confirmation that's saying this is an ETV6 NTRK free fusion. It could be a translocation that maybe doesn't involve those genes. So in order to confer that eligibility for TRK inhibition, you do need some finding that says NTRK is involved. That can be FISH. It doesn't necessarily have to be molecular. You can have NTRK FISH that is performed and does show a rearrangement, in which case that would confer eligibility for TRK inhibition. Or you can do those molecular assays, as we've discussed, that can also identify that NTRK is involved. But yes, a karyotype alone is not sufficient.
Okay, great. I hope that really directly answers the questions. We have a second question from our audience. Are there any published studies describing incremental diagnostic or prognostic gains using whole exome or whole genome sequencing for this kind of sarcomas?
Not that I am aware of. I know within our group internally, we have done quite a bit of testing using exome in particular for many different cancers. And that is some work that is currently in progress. We're trying to get put together as a manuscript. I think probably the best study is the one that I showed previously, which looked at the 7,500 patients and identified the differences between the original diagnosis and then how molecular led to that corrected diagnosis.
Okay. Another question is, apart from larotrectinib for the NTRK3 inhibition, what other drugs would be available as targets in pediatric sarcomas?
This is a great question. So there are, as I'm sure this group can appreciate, testing or clinical trials in the pediatric setting is really limited. There are many different targets that have been identified within pediatric sarcomas that can be targeted by different therapies. So one, for example, a case that we saw was a patient that had a infantile fibrosarcoma actually with a MET fusion. So there are many different MET inhibitors that can be used. At the time, though, that she presented, this was essentially a congenital tumor. Cabozantinib, which is one of the MET inhibitors, actually hadn't been tested in that age group yet. So that is one of the challenges with these pediatric sarcomas is one, is the drug actually tested in the pediatric setting, if there is a drug available. Larotrectinib and entrectinib, both are TRK inhibitors. Both have done a really great job of making sure this particular drug is safe and can be utilized in those really younger patients. But yes, there are other drugs that are available for targets. So MET is the one that comes to mind for cabozantinib, but there are certainly others as well.
Okay, well, thank you for that answer. A question about the use of microarray as diagnostic tools. So do we use OncoScan for this kind of sarcoma analysis? Is that applicable?
Well, if you want to know the copy number, yes, it can be applicable. So there are, I didn't touch on it here because microarray is great at telling you what the copy number is, but it's not great for identifying fusions. Because you can't actually say that there is a fusion that is involved if a gene is disrupted, for example. So yes, you can use microarray. It probably has a better utility in those that have more of the genomically complex tumors. So like osteosarcoma, for example, if you're looking for an amplification of a particular gene, there is certainly utility there for microarray. One of the things that we saw within our work group, again, it's depending upon the different sites. Some sites do microarray more frequently for sarcoma analysis and others do not. One of the great examples that we had within our group that one of our work group members shared was a fusion of, I want to say it was again ETV6 NTRK3 where the fusion was actually picked up by microarray. So where there was a break actually ended up breaking in track 3, and led them to them performing additional testing to then confirm that, yes, actually, track 3 is rearranged with ETV6, and there is a fusion present. So while microarray has uses for copy number, it also has limitations in that it can't actually tell you that there is a fusion present. So something like that, similar to the karyotype question, if you saw that track 3 was disrupted, you're thinking there's a fusion, that particular set of data would not make you eligible for track inhibition. You still have to go on and do that confirmatory testing for fusions.
Yeah, no, that's really important. I don't have any further questions in the Q&A from the audience. We do have a panelist here. I wonder if any panelist has any open questions. We do have a couple more minutes. I do have a question. And if you had a crystal ball and can look into the future, and you've listed some current technologies, some of which have been around for decades, and some newer technologies like the methylation array and the optical genome mapping. So if you had a crystal ball 5 years or so more that from now, where do you think our technology would lead us so that we can, narrow down to the most effective technologies for pediatric sarcomas?
Yeah, I mean, thinking back to one of the issues with pediatric sarcomas is limited quantity of tissue. In some cases, it would be great to have one assay to do it all. And that's like probably way in the future beyond those 5 years looking into the crystal ball. But if you had one assay that could identify a fusion, it could identify variants. I think it's going to be hard to get that methylation in there, and that's still emerging anyway. So we're still, on the fence on how much information that actually provides. But I think if you can have one assay that does both fusions as well as a comprehensive genomic analysis, that would probably be ideal. Whether that is RNA based or DNA based, I think it's hard to tell at this point. But knowing some of the limitations with pediatric sarcomas, I would love to see that eventually happen. That way, everybody who needs the testing, even if they have just a small biopsy, is still able to get the testing that is necessary to help diagnose and treat their tumors.
Thank you. We do have one question from the panelists. So being the chair of the CGC Sarcoma working group, what is the next step or steps for this working group?
Another great question. And we certainly haven't discussed this yet as a group as we're trying to finalize our survey, and we actually have a second paper that's more of an education-based paper. I know from talking with Janelle, I would love to help her and have our work group help her with the CCGA and helping to really get some of these molecular drivers within an easy to use and easy to access database. So that is something that I'm hoping that we could do potentially as a work group in the future. Something else we've also discussed is taking a deeper dive into some of the more specific tumor types as well. What we did not want to do was put out a paper that's just a literature review. There's tons of literature reviews of different tumor types. So we wanted to find a way to make this unique. So seeing if there is a particular tumor type or tumor types that could benefit from more of an educational standpoint, I think would be beneficial in next steps for this group.
Well, we are just about up, and I would like to really thank you, Dr. Schieffer, again for a wonderful talk, really informative.